Hello, my name is Dorina Landa, and I'm the Executive Director of Advancement at the University of Toronto's Temerty Faculty of Medicine. I'd like to begin today's event by acknowledging the land on which the University of Toronto operates. For thousands of years, it's been the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. Today, this meeting place is still home to many Indigenous people from across Turtle Island, and we are truly grateful for the opportunity to work on this land. And I'm so pleased to welcome you today to this latest installment of the Temerty Medicine Talk series. Today's event, Feeding Health, Harnessing the Power of Nutrition in Medicine, has been of great interest to many in our community and beyond. We know we should be eating nutritiously, but advice on what, when, and how we should be eating can be overwhelming and oftentimes contradictory. Today, we're going to hear how Temerty Medicine is educating physicians and other healthcare professionals so they can provide practical and, importantly, scientifically informed nutrition guidance to their patients and families. I hope you enjoy today's discussion and very much look forward to welcoming you to future events. I'd now like to welcome Dr. Trevor Young, Dean of the Temerty Faculty of Medicine, to say a few words.
Thank you, Dorina. It is my sincere pleasure to welcome all of you to this Temerty Medicine Talk. As many of you know, the Temerty Faculty of Medicine is at the core of a research and educational hub within Toronto's world-renowned health sciences network. Every day, our clinicians, researchers, and educators on campus and across our partner hospitals tackle medicine's biggest questions and work to develop innovative solutions that will advance health and healthcare in Canada and beyond. I find myself continuously amazed by the sheer breadth and scale of these efforts. In every corner of the faculty, I find someone pursuing truly important work. Our Temerty Medicine Talks are one way we highlight some of these impactful initiatives. We've delved into some pretty big topics through the series, perhaps none as universal as today's topic, nutrition. At Temerty Medicine, we recognize that a strong foundation in nutritional sciences can help physicians working across specialties and in turn their patients. I'm so pleased by my colleagues' effort to offer and expand the faculty's nutrition medical education programming for physicians in all specialties and at all career levels. Through this programming, we are driving new opportunities to harness the power of nutrition in healthcare. Today, you will hear from 3 faculty members, each with a different area of expertise on this topic. They will share more about what we are doing to improve physician nutrition education, why it is so important, and what lies ahead. I'm also so pleased to have André Picard, the award-winning health columnist for the Globe and Mail, here to help guide today's conversation. André, thank you for being with us. And I should note, congratulations on your recent Arbor Award from the University of Toronto in recognition of your volunteerism and your support of this event series. I'm going to turn it over to you now to further introduce today's topics and speakers. Thank you.
Thank you very much, Dr. Young, for that kind introduction. As you heard, I'm André Picard, and I have the pleasure of moderating this nutrition-themed Temerty Medicine Talk. We rely on our doctors for advice on all sorts of health issues, so it makes sense that we would also turn to them for nutritional guidance, especially in this era where everyone's on a diet, everyone's worried about what they look like. Sometimes we need help. But how can we make sure that doctors have the most up-to-date, scientifically sound information, and their advice is practical and flexible and accessible to patients from diverse cultural backgrounds and different socioeconomic levels? How do you empower physicians and researchers to incorporate nutrition science into their work? These are some of the things we'll be discussing today with our guests, and we also have a lot of great questions that have come in from the audience. We'll incorporate those as well. You can see their full bios on the YouTube video description below, but let me briefly introduce them now. I won't do justice to their fine bios, but we'll at least get their names. So let me start with Dr. VIVIAN Choo. Say hi, VIVIAN. She's a family physician currently practicing at Women's College Hospital in Toronto, and her interests are in the application and promotion of nutrition education in primary care with a particular focus on physician education. So welcome, VIVIAN. Next, we have VALERIE TARASUK. She's a professor at the University of Toronto's Department of Nutritional Sciences and a leading researcher on Canadian food policy, population-level dietary assessment, and probably most significantly for our discussion today, household food security. So say hi, VALERIE, welcome.
Hi, thank you.
Great. And last but not least, we have Dr. Chris Tomlinson. He's the academic lead for child nutrition in medical education at the U of T's Joannah and Brian Lawson Centre for Child Nutrition. And he's a staff neonatologist at the Hospital for Sick Children, as well as a researcher who investigates the growth and nutrition of preterm and critically ill infants. I'm not sure what he does in his spare time, but that sounds like plenty. So welcome, Chris, for joining us.
Hi,
and
everyone.
We have a lot of questions, so I just want to dive right into it so we can take the most advantage of your time. And Chris, I thought I'd start with you if I could. The focus today is medical education about nutrition. We want to really dig into that. So could you start by just telling us, what do medical students and trainees learn about nutrition now? Do they learn anything?
Well, thanks, Andre. Thanks, Andre, for that question. Well, when I go back to medical school, I did medical school in Scotland in the 90s, and I can safely say that our nutrition education was pretty much zero. We've moved on a lot from that time, and through a lot of advances at the Temerty Faculty of Medicine, we have improved a lot, and we've moved the goalposts a lot in terms of nutrition education for medical students. And a lot of that is through the work of my colleague John Stephen Piper and his colleagues at St. Michael's Hospital. We've come a long way, but there's still a long way to go. What we've recognized, and there was quite a lot of literature to support this, that medical students and practicing physicians don't have the information that they feel they need in order to answer the questions of the patients and patients who are in front of them in clinics, in order to answer their questions of what diet should I be on, what should I be eating, how do I get weight loss, how do I even make sure that my children are growing appropriately. And so that is what the most recent donation from Brian and Joannah Lawson to the Lawson Centre is to try and achieve. With that, we are looking to improve nutrition education across the spectrum of medical education, from medical students to practicing physicians. And we're really looking at a multi-pronged attack, if you like, to see if we can really improve the fundamentals of nutrition knowledge that physicians and medical students have.
Great. And Vivian, you graduated a little more recently than the rest of us here, I'm guessing. What did you think of the education you got, particularly that you already had some background in nutritional sciences, so you knew a lot of this stuff? Did your peers, did they learn enough about nutrition in med school?
Yeah, I think this is a really important topic to highlight because contrary to the belief of most of our patients, actually, a lot of us tend to receive very limited hours, at least outside of U of T medical school, dedicated to nutrition, especially in our medical curriculum. And even just thinking back to my own experience, the little nutrition training that we received was mostly biochemical. So we were taught about macronutrients and micronutrients, how to calculate, the amount of calories per gram in fat, carbohydrates, and protein, or maybe, this is what the vitamin A molecule is, and this is what the vitamin C molecule is. But while this, basic science is important, it's not necessarily as useful for us as physicians, when we're at the bedside and we're actually trying to counsel our patients on ways that they could, prevent their next heart attack or prevent losing a limb or their eyesight from diabetes. So I think there definitely is a lot of work to be done in improving the medical education in terms of nutrition education.
Great, and we'll get into some of that, what we should be doing differently a little later. Dr. VALERIE TARASUK, we heard, students don't learn a lot about nutrition. It's sort of technical chemistry stuff, if you will, but they don't learn about other important stuff either, like food insecurity and poverty and the impact on health that way. That's an area of interest for you. How can we do better on that count?
Well, I actually think that we're doing not badly right now. I mean, I think in our faculty, we're having conversations about food insecurity and poverty in relationship to health. And I think some of these problems are very, very deeply rooted. Obviously, food insecurity is very deeply intertwined with public policy, but it's really important for, you know, up and coming physicians to be able to put that problem in context, because one thing we know with certainty is that people who are food insecure, people who are poor, are overrepresented in our health system. So anybody practicing in the health system is way more likely to encounter somebody who's struggling, right? Because they are just so much more likely to need help, to have chronic conditions, to have conditions that derail. So, I mean, I think we are going some way towards beginning to talk about this so that people graduating from programs at U of T are at least literate and have a way that they can put into context the struggles of patients that they're seeing.
But all the nutritional knowledge in the world is not going to help you if you can't afford to put food on the table.
No, it's not, but it's important for people to understand that, so that they're not looking at somebody who's not following a therapeutic diet and thinking what we really need to do is educate you, or, you know, you're unmotivated, that they're understanding that there are, you know, systemic issues that are making it in some cases impossible for people to practice what we think of as a healthy lifestyle. So just that shift in attitude that comes with awareness, I think, is valuable. And beyond that, for sure, I mean, there are many things that people like me would like to see our medical profession do on this topic to exercise their power and their potential, I think, to influence policy upstream. I think there's a whole role for physicians in that realm, particularly with respect to the social determinants of health.
Great. So, Chris, I think we've heard nutritional education wasn't that great before. It's getting better thanks to initiatives like yours and others. But who ultimately decides what students learn about nutrition, and you know, how do you decide? There's so much you could teach them.
Yeah. So the way that we've advanced nutrition education in the U of T medical school is starting off really from year one, building it in their introduction to medicine, and I think it's week 8, as soon as they start to get into medical school. And we look at providing those fundamentals. And we've a very innovative program which comes under the banner of culinary medicine, in which we actually get the medical students to go to a food store. They go around, they look at the food that's available, they budget them, we provide them a budget to buy their food, and then we teach them with that how to read the nutrition facts label. And then once we do that, then we get them actually to prepare the food. So we're actually going from actually thinking of a budget, a menu, teaching them how to prepare that and prepare that food in a way that is healthy. And all of this is to raise awareness, really getting at what Valerie was just talking about how do we put into practice the biochemical knowledge that Vivian was talking about, actually putting, because people don't eat vitamin A, they don't eat vitamin C, they eat food, we eat food. So how do we put that into practice and bring what we call a healthy diet into, so physicians can help their patients choose what is a healthy diet for them, and that will work within the budget that they have. And that's a really challenging issue. In terms of who makes that curriculum, we're working with the rest of the faculty within the Temerty Medical School to make sure that nutrition education is embedded within all of the topics. So for example, we talk about cardiology or nephrology, there's particular websites that the students go to for information on those topics. We've introduced a nutrition tab as well, if you like, so that we can actually, the students can get all their nutrition information from one site, but also embedding it within the curriculum, not so it's just 1 week way back in first year or in medical school, but make sure that they know that when they're talking to, for example, a patient about hypertension and how to treat hypertension. Sure, there's a lot of medications that we use for that, but there's also the DASH diet, the diet against hypertension, that people can use and adopt, that will also enhance their own well-being.
And Vivian, I interact with a lot of medical students, medical residents through my work. In my experience, they don't necessarily have the best diets. They eat out of vending machines and they eat on the run. Is it important for younger physicians to model this, to model good behavior if they're going to be talking to their patients about it?
Yes, absolutely. And I really like what UT Medicine is doing in terms of bringing the medical students into the culinary kitchens and teaching them how to eat healthy and eat on a budget, because this in turn is going to influence their own perceptions of the importance of a healthy diet, and also allow them to be able to provide counseling to their patients around that and the relationship between diet and disease.
I see potential for a Food Network show here, these medical students learning how to cook or something like that.
Certainly.
And what do you, like, I hear from students as well that we have to learn so many things. I just can't do everything. Is nutrition something that you can kind of neglect and still get away with it?
So I think it definitely is important for our medical trainees to at least have a basic foundation in nutrition, particularly, from my perspective in primary care, for a lot of us in family medicine, we're the first point of contact for patients with the medical system, and we do a lot of screening, and we are able to catch a lot of diseases in their early stages before they actually, progress into their end stage complications and end stage sequelae. So, in a way, it kind of behooves us as physicians to be informed and to be aware, and to be able to share potential interventions with patients that may actually be able to shape the trajectory of their illnesses. And I think, if you look at a lot of the societal guidelines, lifestyle and dietary modification is actually the initial step in treatment. So, as physicians, we tend to often skip over that rung and start with the medications instead, either because of lack of time or training or teachers or, lack of confidence in influencing behavior change. But I do think it's very important for us to become aware of that potential that diet could have in modifying the trajectory of our patients' diseases.
And Valerie, people live within a community, they live in an environment that's often described as obesogenic. There's a lot of bad food choices out there that are easier to make than the good ones. How do we get doctors to address that? Can we do that to help people understand the triggers, the thing around them that are making this difficult?
Well, I think we can, and I think Chris and Vivian are probably better able to speak to the ways in which we can just at least alert physicians or educate them around what are good choices. But the other part of this is to look upstream at what are the drivers of that environment, and how do people in the healthcare system interact with that environment in a way that's constructive. So, taking positions on, or engaging with boards of health, taking positions on things like the location of food retail, the accessibility of it. I mean, there's a lot that we can do around the environment if we've got an informed community, and part of that is having an informed healthcare community.
Because we know, for example, that in poorer communities, there are food deserts. It's hard to get fresh food if you live in a poorer part of the city. These are really structural problems that are well beyond medicine.
Andre, if I could just jump in. So one of the projects that we have currently with the Lawson Centre that we're just starting up is with a physician that's working with a very defined community. And what he's going to be doing is working within all the family physicians within that area. There are about 100, and making sure that their basic knowledge of nutrition screening, and we're aimed at children, so we're looking at screening for heights and weights and making sure that they're growing okay. But also within that, expanding that project to work at the community level, and also working with local government within that community to get exactly at that question that you're just asking, is how do we identify food deserts? He's done a lot of background work already within that community, identifying those food deserts, and we can't solve those. Physicians can't solve those in day-to-day interactions with patients, but we can advocate. We can advocate at a community level, at a local government level, and ultimately this does get to bigger picture things about community planning. How do we make sure that there is access to stores close by that people can get to that are budget stores, so they can actually shop on a budget and actually feed their family?
Great. Vivian, I want to come back to that. We had a lot of questions about the interaction between the physician and the patient. How much education can you do in like a 7-minute visit that the doctors often have? We talked about the limits of what you can do, what you focus on.
Yeah, and I think that's a really great question, because obviously being able to provide adequate nutrition counseling definitely takes more than just a 5-minute visit. I mean, at least where I work at Women's College Hospital, we have the privilege of working with dietitians in our healthcare team. So oftentimes I think as a physician, my role is to just bring up the topic of nutrition and make patients aware of that connection between their diet and disease, and kind of use that as a springboard for them to become interested and invested in their health. And then we can sometimes refer off to our dietitian colleagues who are able to provide them with a little bit more practical and tangible advice. But for those of us who don't necessarily have the luxury of working with our dietitians, some other strategies could be being able to provide patients with handouts. So starting the discussion in clinic, but giving them some homework and some readings to do after the fact, or even just saying, you know, I'm really excited to hear that you're making these connections between your diet and disease. I don't think we're going to do it enough justice just to, you know, spend 5 minutes talking about this. Why don't we book another visit where we can solely dedicate that to talking about your diet and going from there.
And you mentioned dietitians. Is some of the solution to this more interdisciplinary work, having people in clinics who are specialized in these issues?
Yeah, I think there's definitely a huge role for collaboration across the specialties. I think, you know, especially at U of T, we have a very unique privilege and unique advantage because we do have a department of nutritional science. So we actually house, you know, very prominent researchers like Dr. TARASUK and others who have dedicated their careers to answering these important questions around nutrition. And it really allows us, you know, the opportunity as physicians to take some of the research that's actually being done in our backyard by leading experts in the field from the bench to the bedside. And there's also a big role for collaboration, as you mentioned, with dietitians as well. I believe the culinary medicine classes that Dr. Tomlinson was referring to earlier are actually led by dietitians. So the med students are actually getting the practical advice and counseling tips that they can then translate to their patients.
Great. Now, Chris, a moment ago, you talked about children, you know, the very youngest, the nutrition can be very important. We know the first 1,000 days of life is really crucial to outcomes throughout your life. How do we make sure that those very specific communities get the education that they need, especially like people who are pregnant, young babies, that they get that good start?
Well, I think the first point of contact for many people when they're pregnant, about to be pregnant, or looking after newborn babies is their physician, and that's what we are. That's what we're really aiming at with the new project, which is my position as academic lead for pediatric nutrition education, is really getting the information that physicians need in their minds when they have a family in front of them, or at least know where to find it. So we're going to make sure that one of our projects is to make sure that the Lawson Centre is that centre for information. There's a lot of misinformation out there, and we haven't talked about that yet. But I believe one of the role of physicians is to debunk the bunk. And I think that starts with knowledge. That's how I think that if physicians are well informed, then they're in a position to provide families with accurate information, make sure that families know that, for example, breastfeeding is best. But if breastfeeding is not possible for whatever reason for particular mothers and families, then how do we fix that? What can we put in place to help that? And how do we supplement breastfeeding if it's not enough? How do we monitor that growth? And that's really what we're aiming at, is make sure that physicians have the knowledge that they need to monitor the growth of children. And then not screening is not enough. And a lot of screening is not done because physicians don't feel empowered by their lack of knowledge to put things in place to fix the problem. And so that's what we're trying to aim for. And we have a series of webinars and e-modules that are coming out in the new year through the Lawson Centre, which are going to aim at a series of topics across pediatric nutrition, really to try and fix that gap and see if we can provide physicians with the knowledge that they need.
And Valerie, one of your areas of research is dietary assessment. Do we know enough about what's going on in the community that we can fix it? Do we have that good base of data?
I think we do. I think we do. I think in Canada we're privileged because we've got very, very extensive nutrition surveillance that happens nationally through Statistics Canada and Health Canada. So I think we actually know a lot. I mean, and that coupled with the research that, other people are doing, people in our department are doing, I think we are very well positioned right now to make evidence-based decisions as they relate to nutrition, and particularly at the community or population level. So yeah, I think it's one of the things we don't talk enough about, because, Health Canada in many ways is a leader on this front, and the kinds of data gathering that have been done and the representativeness of the samples and the ability to go further, I think we do know a lot.
And we have good data, but are we acting on it? What's the data telling us we should be doing?
Well, we've got a constant tension between the evidence and policy making, and that's complicated, right? I mean, Chris mentioned earlier the label and the importance of physicians understanding, what is labeled on a food product and what does that mean. And as you may know, that label is an ongoing, the word for it, it's a moving landscape. We've seen changes to the label in the last few years. We're about to see more changes to food labeling coming forward, with warning signs and things like that. So, the food label, believe it or not, is a very dynamic thing. And there's, it's a controversial thing, but all the more reason then that people in health are up to date on the science underpinning that label and the emergence of the revisions to it.
Great. Now, Vivian, you mentioned a moment ago we want to change the reflex, that doctors don't just go directly to the pill, that they talk about nutrition, changing your diet, etc. Now, people with many chronic conditions, heart disease, diabetes, etc., they can benefit greatly from nutritional advice. I'm just wondering, do you recommend specific diets for them? Are there special diets for special conditions?
Yeah, and there certainly are some promising diets in the literature. Some that come to mind are the portfolio diet for cholesterol reduction. And the reason why I really like that diet is because it was actually created by some of the clinician scientists here at our U of T's own nutrition department. There's also the low glycemic index diet that I like to recommend for patients trying to work on their blood sugar control. There's also the DASH diet and the Mediterranean diet for those who are tending to focus on like blood pressure and body weight. So there certainly are stronger diets that are backed by science compared to some of the more newer fad diets out there.
And how do you deal with that when someone comes in with their fad diet? I'm on keto, or what, the grapefruit diet, or whatever this week's #1 bestseller is. How do you talk to them about that without shaming them or telling them they're making a ridiculous choice? Must be a hard conversation.
Yeah, certainly it's a challenging discussion to be had, but I think a lot of what's driving these fad diets is that marketers and papers kind of need to demonize or sensationalize a particular macronutrient or micronutrient in order to be able to sell. If we were just trying to, promote a paper that said fruits and vegetables are still good for you, obviously that doesn't sound as sexy. So products are often, repackaged and rebranded to persuade our consumers that that they are healthy because they are low fat or sugar-free or gluten-free. And I think the important message for our patients is that it's not just where those calories are being displaced from, but it's what's actually replacing them. So if we think about in the 90s where fat was thought to be the villain, it was taken out of a lot of our commercial products. But in order to make them more palatable, they were actually replaced with a lot of refined grains and added sugars, which probably had comparable detriments to their health. And as you mentioned, Audrey, like now in our society, carbs seem to be the villain, and people are turning to the ketogenic diets or the paleo diets. And, they think that because they're replacing their toast with 4 extra slices of bacon and eggs cooked in butter, that might be a healthy substitution. So I think the underlying message that I really try to get across is when it comes to any macronutrient, it's not necessarily about the dietary quantity, but the dietary quality. So there can actually be, healthy sources of fats, whether that's polyunsaturated or monounsaturated fats that you could find in nuts, seeds, olive oil, versus the, unhealthier fats in saturated fats like animal-based fats or high-fat dairy. And by that same regard, all carbohydrates also aren't created equal. There's a broad range in carbohydrate quality from quinoa to Coca-Cola. And interestingly, high carbohydrate quality foods can actually help with weight loss and insulin resistance due to their high fiber content, which promotes better satiety and better reduction in body fat, which is one of the primary drivers for insulin resistance. So completely eliminating those particular food groups from our diet might mean that we are missing out in important minerals and sources of fiber and nutrients.
You just described my lunch dilemma. Will I have quinoa or Coke, or will I have both? I'll have to decide after we wrap up, but we'll see. Chris, you alluded to this just a few minutes ago, but in this area, I can't think of an area other than nutrition that has more hype, that has more misinformation. How do you help patients deal with that when they hear all this stuff and it's hard to sort it out?
So it's knowledge. It's making sure that physicians have the accurate scientific knowledge that they have in order to respond to that. If you go to the bookstore, the section on diet and health is huge, and you can find a diet for supporting anything, and that is going to cure all your problems. I think deep down everybody knows that that's probably not realistic, but everybody wants to be told, yes, eat a kilogram of grapes a day and you'll be super healthy. Other fruits are available, but that it's just not realistic. And I think it comes from knowledge, and exactly just as Vivian just said, it's making sure that physicians have the knowledge so that they can have constructive conversations with patients from a scientific base to say that, okay, if you want to go on a ketogenic diet, why? What is it you're trying to achieve? How are you going to do it? Provide them with support that they need in order to actually get onto that ketogenic diet, which can work under circumstances, and it can help promote weight loss. But it's quite restrictive, and it does take a lot of effort, and it will probably need to meet with a dietitian in order to make that successful. So make sure that the physicians know that what it entails to go on, for example, a restrictive diet like that, and to provide patients with support for that. But it's all knowledge. It really is, and that's how we debunk bunk, and that's how we've tried to address, for example, vaccine hesitancy with COVID. People have to be presented with the data that is there, and if they choose not to believe it, then I think comes a limit when you can only do so much. You can't, you're not going to get to all of the people all of the time, but we can certainly make a difference.
And Valerie, another kind of misinformation, we kind of think, well, poor people make bad choices, right? They're always eating chips and Kraft dinner, and we're very blamey, but there are reasons for this, right?
Well, and you're right, that's a stereotype, but it's also not that true. When we look at the diets of people who are low income, for sure, they don't have the same options as the rest of us, but it doesn't mean that they don't know what's good for them. It just means that sometimes they can't afford it. So yeah, you're right, it's really important to debunk some of those myths. And also, there's a lot of stereotyping around the idea that like food insecurity and obesity go hand in hand. Well, In fact, they don't. And there's, you know, so these are the sorts of bits of knowledge as they relate to poverty or food insecurity and health. These are the sorts of things that are really important for physicians to learn, so that they're not perpetuating that the stereotyping in their own interactions. But yeah, it's very important, because that stuff is very, very damaging, right? I mean, it's hard enough for somebody who's struggling to make ends meet, but to, you know, to be seeing a doctor who's making them feel like they've somehow failed, or they're, you know, they're not trying hard enough, or, you know, they're dumb, or they're a bad mother. Like, we don't need that, right? We need to be working hand in glove.
And another one, this was one of the questions, we got a lot of good questions from the audience ahead of time. One of them was about, should we be, you know, it's very voguish now, we prescribe exercise, we prescribe food. Is this something you are a fan of? We should just be prescribing stuff for people and that'll magically make them better?
I don't think that we can prescribe enough to solve problems of food insecurity in Canada, right? I mean, you know, we have a big problem, and but this is, so the idea of food prescriptions is absolutely in the vogue. It's yet another idea that we seem to have borrowed from the United States, because there have been studies that show that when people who are, you know, unable to afford the food they need are given food free of charge, they eat it, and guess what? Their health gets better. If we look at the kinds of markers of health that Vivian's been alluding to in her remarks about, you know, diabetes or whatever, we can see improvements. So it's seductive, but when you do the arithmetic and think, well, how many people would we be treating with these prescriptions, and how many, you know, how much money is there for prescriptions? It quickly, you know, we might want to step back and say, maybe we should just deal with, you know, social assistance benefit levels and enable people to buy food themselves. So, but these are the kinds of things that we need to be talking about. And, you know, this is the conversation, or one of the conversations that belongs in the faculties of medicine across this country, right? What is the right way to respond right now? And how do we take an idea that looks really provocative, that appears in the American, you know, medical literature? How do we take that into the Canadian context, where we've got very different ideas about our social safety net, and what is the right place for us to be moving on?
And Chris, related to this, you know, I talked about prescribing food or diets. One of the questions from our audience was, is food medicine? So is that a good approach? I'm interested in your view on that one.
Yeah, and I think that's a really nice way to look at it. We have the Food as Medicine conference every year through the Temerty Faculty of Medicine, and that's getting at that exact issue. It's getting to how can we use food to promote our own health? What makes that healthy diet? And increasingly, we're looking at, for example, the plant-based diet, and we had a whole session on that a couple of years ago, looking at how a plant-based diet can improve health, not just individual health, but also ultimately planetary health, which is another thing that we need to start thinking about as well.
But I'm French. Food is supposed to be social. It's supposed to be fun. I don't like the idea of calling it medicine.
But I think it can be both. You know, I think it can be part of that, and we need to. You're absolutely right, though, that we eat as part of family, we eat as part of culture. And one thing that we haven't talked about yet also is making sure that medical students and physicians are aware of the cultural context in which people are talking to their patients about. I have one anecdote, which was from a colleague who was of Indian descent. And he said to me, there's a big discussion within his Indian community in Toronto about whether or not you can be a real Indian if you bake your samosas rather than deep fry it. And so that's something that's not, obviously it's not on my radar at all, but when you look at the individual level of, that's really deep within the culture, is like, how do you make a proper samosa? And if you're not doing it properly, and when we, say to a family, well, you need to not deep fry foods as much, but then we actually realize that that's really getting at their whole culture. That's just not going to get anywhere. So we need to work much more within that cultural context as well. And that's particularly true within Toronto, of course.
And Vivian, maybe you can expand on that a bit. This is a really cultural issue. There are some illnesses like diabetes are much higher rates in some communities. Some of that is related to their diet. This is complex stuff to get into. Changing people's lives is asking them to change their culture.
Well, absolutely. And I agree with what Dr. Tomlinson said, in that our dietary counseling does need to be very culturally sensitive. Just thinking back to a patient I saw last week, who, we for reviewing his blood work, he actually had a new diagnosis of diabetes. And as I was going through carbohydrate quality with him, he's kind of stopped me in my tracks and said, well, doc, I can't stop just eating rice. And of course, at the end of the day, I would never want to tell any patient that they have to stop eating their staple food. But we did have a bit of a discussion around how he could still continue to eat rice and incorporate that in a healthy part of his diet, whether that was maybe changing that to brown rice or parboiled rice. And then even for cultures who eat a lot of pasta, going back to the idea of the glycemic index, where every carbohydrate is essentially assigned a score. So those that are high glycemic index tend to cause a faster and larger rise in blood sugars compared to those that are low glycemic index. So cooking pasta, to the al dente texture tends to make it more low glycemic index. And also thinking to another patient I also talked to last week about, she was telling me she ate a largely Caribbean diet, and plantains were a big staple in her diet. So we chatted a little bit about, what would it be like if we tried to balance out her plate a little bit more? So still having the plantains, but also incorporating fiber, lean protein, and fat, because eating those in conjunction with carbs also helps to slow down the glucose spike. So I think it is important to keep in mind that it actually is possible to allow patients to incorporate their traditional foods in a healthy eating plan. And just one last note on that, a resource that I actually like to refer patients to is on nutrition.gov. There is something called the My Plate Kitchen, and it's actually an online tool featuring a collection of healthy and budget-friendly recipes from different cultures. So from Latin American to Mediterranean, Asian, even indigenous recipes. So for myself, I sometimes like to refer patients to that as a way that they can consider using, their staple foods and traditional foods in a healthier way.
Great. Now, unfortunately, we're almost out of time. So I want to ask each of you a final question, bring it back to the research element. You're all researchers. And I want to know, what do we not know about this field that we should? What are your research priorities? Maybe I'll start with you, Valerie. What do you want to know?
Oh, Andre, what I want to know is how to create the political will to deal with these systemic issues like food insecurity or poverty. That's what I would say. I feel like we know, at least from our research domain, we know a lot about what moves the needle on things like food insecurity. But what we don't know is how to create the political will so that we have a social safety net that does not set people up to be unable to follow the good advice that they would get from someone like Vivian.
Right. Chris, what do you want to know that you don't know?
How we enable an environment for children to get optimal growth and development. And that's not just diet, it's also exercise, it's optimal schooling. It's all of those things put together. How do we do that in order to optimize the health and outcome for all of our children?
Great. And Vivian, you have a long career ahead of you. What do you want to learn?
I guess just putting on my education scholarship hat here, I would really be interested in effective ways of integrating nutrition into the medical curriculum and what that might look like.
Wow, but that's a big one. That'll be a career's worth. So unfortunately, I have to say we're out of time. So that concludes our today's Temerty Medicine Talk. I want to thank our guests for a wonderful conversation, Dr. Vivian Choo, Dr. VALERIE TARASUK, and Dr. Chris Tomlinson. For those watching live, please look to the link to a brief survey in the chat window. We'd appreciate you taking just a couple of minutes to provide us with some feedback so we can do a better job in the future, talk about some topics that you're interested in. Thank you, of course, for sending in your questions. Unfortunately, Unfortunately, I couldn't get to all of them. There were a lot. And thank you again, everyone, for joining us. And we hope to see you at this next Temerty Medicine Talk. Bye.